Emma Nichols. Dr. Nichols is a research scientist at the University of Southern California. She received her PhD in epidemiology from Johns Hopkins Bloomberg School of Public Health in 2023 and her MPH from the University of Washington in 2019. Her research interests focus on cognitive aging and dementia, as well as methodological problems common in epidemiological studies of older adults. Her work, her current work focuses on international aging studies and cross-national comparisons. And I have the honor to be part of the HCAP studies in the MaxCog. So I've met Emma Nichols before, and I've heard a lot about her work and about her studies, and they're very interesting. And I hope you all will find them as me so interesting. So Emma, nice to have you here, and you can start.
Great, thanks so much for the introduction. I'll go ahead and share my slides. All right. So I'm really happy to be here and excited to talk to you all about a sort of broad range of work that I've been involved in and led, broadly focused on methodological challenges in cross-national research on cognition and dementia in the Harmonized Cognitive Assessment Protocol, or HCAP surveys. So I'm going to start by just giving a broad introduction to the Gateway to Global Aging data and the HCAP studies. I think this is an amazing data resource. It might be a little biased, but just to give you all an orientation to what's available in these studies and the resources that are publicly accessible online. Talk a bit about cross-national cognitive measurement, some of the challenges that arise, some of the solutions that we've developed to address those challenges, and some sort of things to keep in mind using these data. And then the third section will focus on some of the challenges in longitudinal analysis of the HCAP data, focusing in this section specifically on the Lossy-Dodds study, which is the longitudinal aging study in India, diagnostic assessment of dementia, so the India HCAP study. I'm a co-investigator on this study and sort of more greatly involved in research using Lossy-Dodds. I'll talk about both practice effects and interwave mortality. So starting with the introduction to the Gateway and the HCAP, all of this really started with the health and retirement study and the international network of studies that followed. So the HRS, or Health and Retirement Study, started in 1992 as this nationally representative study of older adults in the US. And you can see between 92 and about 2000, it's really just the HRS in play. And starting in 2002, we add new data from MHAS from Mexico. And then over time, this network has just grown and expanded with new data coming in from a number of different countries and sort of fleshing out the global coverage of these comparative data resources. And here you can see now in sort of map form, the geographic coverage of data across the world, covering a number of different diverse settings. And in terms of sort of what makes a study belong to this network, so what makes the HRS, all these studies share in common that they're population representative of older adults. They include longitudinal interviews with comparative survey measures. They include multidisciplinary content, so covering cognition, but also a variety of other domains that are important to older adults. And importantly, they're publicly accessible, so available for scientific use across the research community. The Gateway to Global Aging data is a platform and a project that has enabled sort of greater level of detail to harmonization across these studies and providing resources to facilitate cross-national longitudinal studies using these data resources. And so there are a number of things that the Gateway does and provides. So I'll just do a very quick whirlwind tour through some of the useful features here, showing a snapshot of the website. On the website, we have study overviews that provide links to the study cohort profile paper and introduces the study sampling framework. So here showing the page for MHOS with the cohort profile paper linked. We highlight the timing of interview collection and provide information on other types of surveys fielded in conjunction or in collaboration or sort of nested designs. We also provide information on different refreshment samples, highlighting participation by wave and listing the different types of administrative linkages that are available. And then we also have sort of this easy to use interface that includes information on the survey questionnaires across the different interviews that are included. And this includes as well information about the order of modules and the order of questions within modules, as well as individual survey question text and answer choices. So this you can sort of dig into each survey in turn, but then you can also look at question concordance to see the availability and comparability of survey questions across time and between studies for selected topics. So this is really useful when you're trying to sort of plan cross-national research. And then in addition to these sort of online tools, we create harmonized data sets that provide comparable research-ready variables. So this is intended really to jumpstart analyses and take out some of sort of the upfront work that's necessary when doing cross-national research. So variables are designed to be defined as similar as possible across all waves and studies. All variables use intuitive variable names, including both variables for the respondent and the spouse, with harmonized names where the variables are harmonized, and then some study-specific names. And all of these harmonized data are created in collaboration in conjunction with the different study teams, ensuring sort of the maximum accuracy and validity of these data sets. The code books that accompany these data sets also discuss a number of details related to weighting and imputation and the harmonization process, as well as summarizing the data and listing all the variables from the originating data set that are used in the creation of the harmonized variables. There's a couple, so that's sort of my whirlwind tour of what we currently have in the Gateway and what's available for researchers. I'll go through a couple newer initiatives that are either recently available or will be available soon. We've been working really hard on this Policy Explorer, and the idea here is that we're collecting contextual information on policies that are historical in nature, maybe changed over time at the time and place of each of the surveys. So we collect these policy details and index them by country and year, and then publish them online. So you can download the details of these different policy reports on topics like retirement, long-term care, education, and COVID-19. And we're moving towards as well creating harmonized variables that describe the nature of the policy for a given respondent, given their location and age. And then the second initiative is around the exposome. So thinking about aspects of the physical environment like PM 2.5, NO2, green space, temperature. So we currently have data linked to 6 countries, which has been done in collaboration with study teams. And our website currently contains information on the source data visualizations and a user guide with publicly available data to come via the enclave. So we're very close to publishing data on for the Lassie Dodd study and for the ELSA study as well. So just a plug, if you know anyone going to the Gerontological Society of America conference, we're hosting a workshop that will help people get sort of jump started on a project using this exposome, linked exposome data. And so that's available to apply to. The call is still active. So that sort of summarizes some of the new initiatives and some of the additional data and resources that are available. In terms of research on dementia and cognitive decline, the HRS network of studies do have a very brief battery of cognitive tests in the core survey, but this is quite limited because these surveys cover sort of a wide and broad range of topics. There's only so much you can do on any one given domain. And so in order to facilitate and promote research on cognitive aging and dementia, an additional sub-study called the Harmonized Cognitive Assessment Protocol was sort of developed and designed to enhance measurement of cognition among a subsample of people in the health and retirement study. And so this sort of general map shows the sort of status of the available HCAP studies, as well as data that are currently being collected or where data collection is planned. And you can see sort of just to point out what's available in North America. For the US HRS, there's one wave of data available, with the second currently being collected or almost ready to be released. And then in Mexico with MHAS, we currently have 2 waves of data available publicly. And so you can see this network has really been growing and expanding, especially in recent years. And this is a really great data resource because a lot of the measures included in the HCAP protocol provide a much more in-depth understanding and look at someone's cognition and function related to dementia. And this list includes all of the items that were part of the original HCAP protocol. So this is the protocol that was implemented in the US, and I'll go over sort of the reasons why and how this has changed across the different countries as the HCAP has been fielded in sort of broader regions. But in terms of what was included in the US, this includes the mini mental state examination, as well as sort of this broader list of more in-depth neuropsychological tests covering domains including executive functioning, memory, language fluency, visuospatial functioning. This battery is designed to take approximately an hour. And then importantly, it also includes informant reports for every person in the HCAP. So in the core survey, informants are often used, but only when individuals are unable to complete cognitive testing. But in HCAP, we actually have both respondent and informant information on everyone in the sample, which comes into play in thinking about some of the algorithmic work that has been done across the different HCAPs, which I'll get to a little bit later. So now that I've given that sort of general introduction, I want to focus a little bit on some of the methodological issues and solutions that we've implemented in terms of cross-national cognitive measurement. I think it's important to start by thinking about and considering why harmonization is needed for the HCAPs. We could just administer sort of the same protocol in all settings, but really it's clear and that adaptations are needed. You could do that, but you wouldn't get valid data. The most important thing is to collect valid data across all settings. And some items just may not work in different languages or across different settings, as well as across different settings, there might be higher levels of illiteracy and innumeracy, which could affect performance on specific tests that require reading and require using numbers. Context and culture can also play a big role. So the example that our team commonly gives is this item, what is a prickly green plant you find in the desert? And Google, as well as people in North America, will typically tell you that the answer is cactus. But this might not be true in all places, and differences in the availability or just the presence of cacti across different settings may impact people's performance on this item regardless of their cognitive functioning. And that's not what we're trying to measure. What we're really trying to measure is cognition. So one example comes from the Lassie-Dodd survey. And so a priori, we didn't think that cactus would be a good item in Lassie-Dodd because of sort of the lack of familiarity.
Emma, you're muted.
We cannot hear you, Dr. Nichols.
Miss Emma.
Your voice is not it's not there.
My voice is not there. There you go. Can you hear me now?
Thank you. Now we can hear you. Thanks a lot.
Okay, I didn't change anything, so hopefully this stays, the connection stays good.
Thank you. We will let you know anyway.
Okay.
Thanks a lot.
Okay, so I'll just pick up from here. I guess I was talking about the use of this adaptation of the cactus item to coconut in La Ciudad. And this data comes from wave 1. And you can see across states the different proportions responding correct or incorrect. But what you notice here is that if you look at the states that I have included green arrows for, you see the proportion that respond correct is much lower. And in contrast, the blue states, the blue arrows, point to states where the proportion answered correct is much higher. And looking at just the geographic distribution of these states, the states with blue arrows are in the south with borders to the ocean, and the states with green arrows are in the north and they're landlocked. So you can see even within India, differential familiarity with coconut was also still a problem. In wave 2, we changed this to an item on naming a tree, which showed more consistency throughout the country. And so I think highlighting a couple points, one, culture and context being a really key problem to keep in mind, and also to needing to sort of be nimble on your feet and willing to adapt to new information as it comes in. And so with this in mind and the need to sort of adapt and change items to fit each context, this plot here shows the different cognitive test items that were included across the published HCAPs as of 2023. And so you can see there are areas with pretty decent overlap across the different HCAPs, particularly in the memory domain, but there are also areas such as executive functioning where a lot of the items have sort of high requirements for numeracy where the overlap is much poorer. And so this brings us to this idea of, like, with all of these different adaptations and changes to the battery, how do we decide what is a common test item cross-nationally? And within country, this really amounts to a lot of accounting work. And with the between study comparisons, we have developed this general framework and protocol around pre-statistical harmonization of cognitive data, which has really been led by Emily Roseño and Miguel Arce Renteria, who are the neuropsychologists leading this team. But the multidisciplinary team includes people from a lot of different disciplines and is focused on identifying differences in cognitive construct measurement across languages and cultures that may not be identified by statistical procedures alone. And this process really focuses on a variety of considerations. You need to collect all available documentation about cognitive instruments, including different test versions, adaptations, and administration procedures. You need to understand the theoretical and empirical score ranges, as well as the language of administration, to consider cultural and linguistic equivalence. In this protocol, we consider focusing on test items rather than summary scores where reasonable, to understand whether, a summary score might not be comparable, but some of the specific test items within that summary score may be. And then with all of this information, you can then make judgments about the comparability of these different cognitive test items. Once you have those judgments and you understand what is a common item versus an item that's different across countries, you can rely on statistical tools, particularly coming from the psychometrics and item response theory, to conduct statistical harmonization of the different test batteries in spite of differences between studies with the individual items, as long as you have some common items between countries. So this flowchart gives a sort of general overview of this fixed parameter calibration process. And I won't go into the sort of nitty gritty of the statistical details, but just to give you like a general overview of what this process entails. You start from study 1 and conduct this pre-statistical harmonization, as I was just mentioning, to have this list of harmonized items. You then use item response theory calibration to estimate parameters. So these item parameters are numbers that reflect the performance of the individual items. So each item has its parameters, and that describes the performance of that item and the way it relates to the latent trait you're trying to estimate, which here is cognition. You can then start from each additional study in turn, and with the same pre-statistical harmonization steps, you would do a second IRT calibration to estimate item parameters, with the difference being that you already have some item parameters that are in the item bank. So for those parameters that are in the item bank, so these are items that were administered in both wave study 1 and study 2, you hold those constant. And that allows the scale to be anchored between studies. And then you can add to the item bank any new items that were in study 2, but not study 1. There's this additional step called diff detection. And what this does is it adds the second layer of checking to make sure a common item is truly a common item. So in addition to the theoretical free-statistical harmonization, we also do this check to make sure that statistically, based on the data we've collected, there are no differences between items we previously considered to be in common between the studies. Once you have all of the items in the item bank, so all of the items across all the studies, whether they're common or unique to different studies, get added to the item bank as each study is added in turn. You can use the parameters estimated in that item bank to then estimate factor scores or latent estimates of the underlying cognition that we cared about. And once you finish that process, those estimates will be directly comparable between studies in spite of differences in the design and collection of the different items across studies. So this is a really, I think, innovative way to think about harmonizing cognition, but it relies on this assumption that we have common items between tests, and it uses those common items to anchor the scale. So we had this question
a question there. Do you mind, Dr. Nichols?
Yeah, sure.
Can I? Okay, yeah, it's okay. We use IRT theory as well for the questionnaires and different levels. And in this case, when you mentioned that there are some fixed, just talking fixed question across to the questionnaire, is what you are saying?
I'm saying there's some questions that are asked in both. So if you think about only 2 studies, you might have a question that's asked in both study 1 and study 2. And the way this process works is you estimate all of the parameters of the model using data from study 1. And then when you're estimating study 2, you actually fix the parameters. So you don't re-estimate them. You set them to be the value that you estimated in study 1. And so in doing that, because you're not re-estimating those parameters, you're assuming the parameters are the same across studies. You're anchoring the comparison between study 1 and study 2 by assuming those items in common perform exactly the same across settings.
You mentioned at the beginning that you use weight for them. Use the weight in this case? How do you weight these questions? Or you don't weight in this case, just to use the comparison to fix the parameters without any weight?
You mean like weighting the different questions?
Because you mentioned that you weighted at the beginning when you started the lecture. You mentioned that, but I'm not sure if you're using the same weighting here or is you're using a different strategy in that case.
Do you mean like person-specific weights, like survey weights?
I'm kind of asking because you mentioned you weight. I want to ask how you weight and what variable you use for weighting. But I don't know if you just mentioned just in a case isolated, not related to this one. I'm sorry, because I'm confused.
Yeah, I think that might have been a different example. So in this, we're not using any survey weights because we're interested in cognition in these people. If you're thinking about sort of like relative weighting of the items in terms of the overall summary score, in IRT paradigm, the different items will contribute to the summary score differently based on the estimates that you get. So the item parameters. So an item that has a stronger association with the underlying construct of interest has more importance in the overall estimate of cognition that you get from the model.
Okay. Now I understand that. So the IRT is the main tool that you are using right now for harmonization. That's okay.
Yeah.
Thank you so much for the
no
clarification.
Problem. Yeah, so this works really well when you have common items. So one thing that our group dug into is sort of what to do if there's little or no overlap in the items that you have. And this might be the case in specific cognitive domains and specific studies. As you saw with the sort of heat map, there are some areas of that, especially in executive functioning, where there's not a lot of overlap between studies. And so the idea behind this work was to understand whether we may be able to leverage a related trait that's closely related to the domain of interest that we're trying to harmonize, and pull information from that related trait in order to sort of create a harmonization in spite of not having any linking items. And this flowchart walks you through how we did that. The general sort of framework on how this is done is that we fit sort of unharmonized models to estimate the trait of interest in both samples. Here, they're labeled as the reference sample and the target sample. You can think of this as study 1 and study 2. And so we have these two estimates of, say, executive functioning in study 1 and study 2, but they're not linked. What we do is we take the linked estimates of general cognition, so a related trait closely related to executive functioning, and we know that we can harmonize these. And so we take these harmonized scores and we use linear equating to essentially take the two unharmonized scores and use the difference between samples from the harmonized scores and adjust these domain-specific scores to have sort of the same relationship between studies that was observed using general cognitive functioning. And this creates this, what we call the LLRT equated scores for the subdomain of interest. So this requires sort of stricter assumptions about the relative relation between the samples in the related trait and the subdomain of interest, but allows for this linking in cases where we don't have any common items. So in terms of sort of takeaways on this section on harmonizing cognition, we know that in cross-national settings, it's unlikely that the exact same cognitive battery will be administered across contexts. We talked about how harmonization is still possible via statistical co-calibration, but this requires common items, and the quality of the harmonization depends on the quality of the common items and the assumption that these are similar across contexts. And then finally, I briefly mentioned that even without common items, there are still options such as this LLRT approach, but they do require these even more stringent assumptions. So you have to think critically about the assumptions that you're willing to make and whether they apply in your data set. So I mentioned at the beginning about sort of these two pieces of the HCAP protocol. We have the cognitive instrument, and then we also have the informant reports. I'll talk a little bit about some of the challenges with the informant report measures. As I mentioned previously, these provide this unique and important perspective and is really critical on in terms of collecting information on those who can no longer complete cognitive tests and core surveys as well. Just to highlight one area in which these informant measures are quite important. This flowchart comes from the Manley-Jones algorithm that was developed in HRS HCAP and has since been a similar sort of algorithm has been implemented across a number of the HCAP studies, but shows here we start with cognition, but we then use informant-rated impairment to critically distinguish between dementia and MCI, and in some cases between MCI and normal. And so thinking about how these classification approaches are being used to define dementia in these samples, the informant-rated impairment is quite critical. I've done a little bit of work sort of thinking about comparisons of these informant measures across countries, and this figure shows the relationship between IQ code total score, which IQ code is an informant measure included in the HCAP battery. So the score ranges from 0 to 5, and this is the mean score across all of the items. And comparing that to an estimate of general cognitive functioning using data from ELSA HCAP in England, HRS HCAP in the US, and Lossy Dot in India. And so what you can see is that in both of the two high income settings in England and in the US, among people with higher cognitive functioning, there's essentially sort of no relationship between cognitive functioning and informant-rated impairment on the IQ code. And there's this sort of sharp knot at about 1 standard deviation below the mean, after which there's a strong association. And we don't really see this in Lossy Dot. We see more of a flat association across the entire distribution. But there is heterogeneity that we see. So if you break out the Lossy Dot sample now into those with some versus no education, there's some evidence here just visually that the some education looks a little bit closer to what we saw in high income settings as compared to the no education group. And so visually, this is what we see, but I also wanted to provide sort of quantitative evidence of this. And so you can directly compare the slopes of two lines if you impose a knot at about 1 standard deviation below the mean, and then compare the slope above that and below that across these different subpopulations, you can then compare those slopes and understand whether there are differences. So you can see, large, strong evidence of these differences, both in HRS HCAP and in ELSA HCAP. But then in the Lassie-Dod sample, we see sort of no difference in the no education group, and then differences in some of the items, and sort of just a smaller magnitude of differences in the some education group. So this is just recapitulating what we visually saw in terms of statistical quantitative evidence. And in addition to thinking about the relationship between the cognitive scores and the informant reports as a way of understanding how these informant measures are functioning, we can also think about differences in who the informants are across settings. So this table shows for the 3 studies, Lassie-Dod, ELSA HCAP, and HRS HCAP, the characteristics of the informants across these different contexts. I just want to highlight a couple things. First, looking at the different relationships that people have. In ELSA HCAP and in HRS HCAP, the close to 50% of the informants were spouses or partners. But in Lassie-Dod, it's almost half that. And we additionally have this new category of child-in-law, which didn't exist in ELSA HCAP and HRS HCAP, but which includes 27% of the informants in the Lassie-Dod sample. So this really is a different perspective. And you can see this reflected in looking at the different generations of the informants, with close to 60 to 70% of the informants of the same generation in the US and England, whereas about 60% of the informants are of a younger generation in Lassie-Dod. And so we know there are these different informants, but they may also have different perspectives on the respondent of interest, and that may cause them to report on their impairment in different ways. And so what you can do is sort of estimate the difference in reported IQ code score by informant characteristics, after adjusting for a lot of the characteristics of the respondent, as well as the respondent's subjective cognition, as one way to sort of get at what is the effect of having an informant, for example, that's a child versus a spouse or partner. And so I did this across the different settings here in this study. So this shows a few of the different characteristics. So here, looking at the different respondent relationships, generations, as well as caregiver status and a few other characteristics. I'll just highlight a few here. We saw that informants that were younger generations compared to those who were the same generation were more likely to report greater impairment in the US and in England, but this was not the case in India. And then informants that were caregivers were more likely to report impairment in the US and England, but less likely to report impairment in India. And then thinking about the gender of the informant, informants that were women were more likely to report impairment, slightly more likely to report impairment across all settings, but this did not reach statistical significance in the Lassie-Dod no education group. But I think just showing that not only do these informant characteristics matter, but the relationships between informant characteristics and reporting, even holding objective cognition constant, varied across setting. So I think in terms of takeaways from this work, we see some evidence that informant reports may function differently across contexts. And I think this sort of requires some further research into how we might account for this in subsequent uses of the informant reports, and also showing some need to pay attention to exactly who the informant is. And one way to potentially account for this would be to adjust for different characteristics of the informant in models that use the informant reports as outcomes of interest. So that sort of wraps up a lot of the content that I wanted to cover on sort of the measurement cross-nationally, thinking about the measurement of cognition via objective cognitive testing, as well as some of the measures that are derived from informant reports. And so I want to spend the rest of the time talking about some of the challenges that we've thought of and the solutions that we've developed in thinking about longitudinal analysis of the HCAP. This work focuses on the Lossy Dodds study, but I think some of the lessons learned may also apply to other HCAPs and potentially other just like longitudinal studies of cognition as well. But a lot of this is pretty new, and as a lot of the HCAPs are starting to collect and release second waves of data, I think a lot of this work can guide how we're thinking about analyzing this. So the first piece I'll talk about focuses on practice effects, and this is, right, I think people are aware this is a notion that performance on cognitive tests can improve due to learning. And most people think of this as a nuisance factor to adjust for, rather than sort of separate and apart from this cognitive decline process that we're typically interested in. I highlight this paper, this practice of epidemiology paper published in AJE, Hop, Skip, and Jump, Modeling Practice Effects and Studies of Determinants of Cognitive Change in Older Adults, which is a really well done piece comparing different approaches to adjust for practice effects. But one thing about this piece is that all of the approaches implemented here and the typical approaches that have been used across different studies typically require at least 3 waves of data whereas in Lossy Dodds and in most HCAP studies right now, we only have 2 waves. So in Lossy Dodds, as I mentioned, we only have 2 waves, but what we do have is a refresher sample covering the entire study age range. So in the second wave, in addition to following up people who had previously completed wave 1, we added a new sample of individuals covering the full age range, both to backfill to younger ages to ensure that the sample remained representative of the population 60 years and older, but also to sort of refresh the general population and account for mortality. So what we can do, given this design, is compare the refresher sample to those who returned to wave 2. And generally speaking, the biggest difference between the refresher sample and those who returned is that especially given that both the refresher sample and those who returned were part of the initial Lossy survey that was the broader HRS style survey. Given that design, the biggest difference is that those who were the returners had previously participated in wave 1 and so had prior exposure to the cognitive battery versus the refreshers did not. So we can leverage that comparison to estimate practice effects. To make this a fairer comparison, we did 2 things. First, we limited the sample, the wave 2 sample, to those who would have been eligible for wave 1. So in wave 2, there were some geographic expansions, as well as I mentioned, we backfill age. So we limit to make sure that everyone in our sample to estimate practice effects would have been eligible for the first wave of Lossy Dodds. And then we also use inverse probability weights, or IPW, to balance the sample and other characteristics. And this involves estimating models for the probability of treatment here, which is exposure to the prior cognitive testing. And then we can use those estimates of the probability of exposure to treatment to weight the samples to be more similar. So these, I don't expect people to read all of these characteristics on the y-axis here, but these are all different demographic factors and socioeconomic characteristics that we might care about making sure are equivalent between the returner and refresher samples. And the blue dots show the difference, the standardized mean difference between the 2 sort of here treatment groups, those who had exposure and did not have exposure to prior cognitive testing on each of these characteristics. So you can see, for example, big difference in terms of the age distribution of these 2 populations. But the orange dots show the differences after weighting, which illustrates that the weighting that we did with IPW really minimizes the differences between the groups. So when we make the comparison, we can feel more confident that this is due to the prior exposure to cognitive testing and not any of these other characteristics.
It's interesting that few variables are no more than 0.4 standard deviations. Still, I mean, it's within 1 standard deviation, right? Because the difference is standardized, right? It's a z-value.
Yep.
Okay, but very nice.
Yeah.
Yeah.
But we really minimize the differences after weighting. One thing to think about with these balancing weights and to make sure of is that there's area within all areas of the distribution, we have good sort of overlap and able to compare those with the treatment versus without the treatment. The way you visualize this and assess this is to look at the distributions of the propensity score, where here the propensity score is this probability that we're estimating from these weighting models. And I was worried a bit about this area out here in the left tail, where we have a lot of people without treatment that have a low propensity score estimate, but not that many with treatment. And so there are a variety of different approaches you can use to help with this. What I implemented was something called strummer trimming, where you essentially cut the distributions and exclude people below the 5th percentile in the treated and the 95th percentile in the untreated. So once you do that, you have to recalculate the weights. Here's just to show you that the recalculated weights also balance quite well. And now we have a little bit better overlap. There's still sort of this area where overlap is not as good, but now here at least we have people in both groups at all areas of the propensity score distribution. Once we have these final weights, we can then estimate practice effects using linear models that essentially just compare those with treatment, so prior exposure to the cognitive battery, to those without treatment or without this prior exposure. That would be the refresher sample. And so you can do that using like general linear models. And these plots show the result of these practice effects models. And so if you look just at this general cognitive performance estimate in the left panel, you see estimated practice effect of about 0.05. This is marginally statistically significant. So this is the overall practice effect, saying that people who had prior exposure to cognitive testing performed at about 0.05 standard deviations better than those without prior testing. But this did vary quite a lot across domains and across the different individual tests that we looked at here. And then on the right-hand panel, rather than looking at the difference in score, what I'm showing is the odds ratio for missing data, comparing those with practice to those without. So the idea here was that potentially prior practice would make people less likely to skip a cognitive test and less likely to have missing data. We don't really see any evidence that would support this hypothesis. So to wrap this up, some takeaways from this analysis on practice effects. We saw some evidence of a small practice effect overall. This was marginally significant, but we did see that the results really varied quite widely by specific cognitive domain or test item. And I think the big takeaway from this is we see some evidence of practice is not large, and potentially this is due to the 5-year age gap between waves. And for many research questions, practice effects may not matter, but you can use this paradigm in comparing the refresher sample to the returning sample to test whether a practice effect is differential by the exposure of interest. And so this would be, for example, if you're interested in the effect of education, would people with education be more likely to have a stronger practice effect than those without education? And that's really, I think, what could lead to bias in substantive analyses, and something that investigators should likely consider. So the other sort of methodological feature or issue that I sought to look at with the longitudinal lossy dot data is tackling concerns around interwave mortality. This is particularly important in lossy dot and likely in other lower and middle income settings where we are collecting now longitudinal data on cognition among older adults where we expect high levels of mortality. This may have been exacerbated even further in lossy dot because wave 1 and 2 happened to sandwich the COVID-19 pandemic in India. But I think the concepts and the notions are still broadly applicable. You can see that just looking at the raw data, about 24% of the individuals from wave 1 died between waves. And you can see here this estimate's now modeled using Kaplan-Meier curves. And we see sort of generally greater mortality among men, among those with of older ages. And we looked for sort of geographic heterogeneity, but did not find strong evidence of this. We also saw really strong evidence of links between mortality and a lot of the clinical and dementia-related phenotypes. So here I'll highlight just these two estimates with sort of a really strong increased hazard of death for those who had dementia at wave 1, and really strong inverse effects for cognitive functioning and the continuous cognitive measures. So suggesting that those with higher cognitive functioning were less likely to die between waves. So all these sort of went in the expected direction, but just to say that if we're looking at longitudinal evidence, a lot of, so mortality will likely be strongly associated with our outcomes of interest.
For Nichols, another question. I'm sorry, just because I'm trying to grasp all the information you are giving. So in this case, it's not redundant. And not expected that you are predicting dementia. You're going to have problem with the memory, language, executive functioning, etc. And for example, I mean, at least I would be interested in the obese, systolic blood pressure, diabetes, etc. Right? So in this case, you put all to. I mean, sorry. The question is, I understand in this case, of course, we're waiting for dementia. Should be is a lot of difference between the cognitive function, how you're showing it. So when you put the diabetes and obesity, is adjusted. I mean, all of these were adjusted. No.
No, so they're actually all from separate models. So the idea here was to do just like a descriptive analysis of like what are the features that most strongly predict dementia status. So I think all these models are adjusted for age, gender, and socioeconomic characteristics. So things like education and per capita consumption, but none of these adjust for each other in the model. So the some of the effect, for example, of diabetes could be sort of or some of the effect of dementia, like they're interrelated because people with dementia are more likely to have diabetes, et cetera. The effects would be reduced if they're all in the same model, likely.
Right. Do you use propensity score for this specific analysis or don't?
No propensity
No,
score
okay.
in this analysis. It was just covariate adjustment for demographics and socioeconomic status.
Okay. Yeah, thank you. I'm trying to follow
Yeah,
everything.
sorry, I'm trying to cover a lot and I'm jumping around a little bit. So the clarification questions are definitely helpful.
Thanks a lot. Yeah.
So because of this, because of the high mortality and because it's strongly related to the outcomes of interest, we wanted to think about the performance and potential of different approaches that could potentially account for mortality, especially when we're thinking about measuring longitudinal cognitive decline, as well as sort of associations between risk factors and decline. So the goal of this project was to compare possible adjustments, so methodological and data adjustments that we could make to account for mortality in a simple example analysis. So in this example, we took analysis that would just essentially estimate the rate of cognitive decline across 3 different age groups based on age at baseline. In this project, we excluded those who were lost to follow-up for other reasons, just for simplicity. Here, we're really just focusing on mortality. And this model is the model that we're estimating for the rate of cognitive decline across age groups, where we have the intercept term for the time, age group, as well as the interaction between time and age group. And this will, linear combinations from this model will give you the rate of decline in 60 to 69-year-olds, 70 to 79-year-olds, and 80 plus. We used a few different approaches that we wanted to compare in terms of ways to account for mortality. So everything is compared to a base model, which doesn't account for mortality at all. And then we compare this to first a weighted GEE model, which estimates a similar inverse probability weight to the one I was describing earlier, but here now for dropout due to mortality. And then also estimates a joint model, which essentially is a linear mixed effects model with random intercepts, estimated concurrently with a survival model that includes an effect for current cognitive level. And so this inclusion of an effect for current cognitive level in the survival model is the parameter that links these 2 models and allows you to estimate them simultaneously. And this prior simulation and methodological work has shown this can help account for interwave mortality. And then we wanted to compare these sort of pre-developed existing approaches to this fundamentally different approach, which used added data based on imputations. And so what these imputations represent, or try to represent, is the cognitive level prior to death. And we get this information predominantly from this exit or end of life interview that we conduct with the next of kin, the relatives or friends of the LACIDAD respondents when we follow people up at wave 2. And so in addition, when we follow people up and we learned that they have died between waves, we conduct this interview and we ask questions not only on when the person died, but also some questions on their cognitive status before death, including some of the same measures we also include in the informant interview. So this includes things like the JORM IQ code and blessed batteries. So we can use these imputations and just incorporate them into our base model, but we can also add them to joint models as well. So we test both these out, both just adding the imputations by themselves and then adding both the imputations and the joint model. I'll just caveat this all with what we're going to do is compare the estimates of cognitive decline across all of these different approaches, but we're using real world data from the LACIDAD study, so we don't actually know sort of the true underlying rates of cognitive decline. I'll just go through briefly some of the details of imputations. I mentioned before, these come from predominantly the end of life interview data, and they ask about cognition 1 month prior to death, in part to avoid including information on sort of terminal decline. We were a little bit worried about the data quality in some of the end of life interview data and some potential reporting biases, in part because when you compare the informant reports from the exit interviews to the informant reports that we got in wave 1, there were a large number of people, and this is sort of broken out by the time elapsed since wave 1 visit. So this is the time between wave 1 and death for all the people who died between waves. We see that a lot of people, when you compare these two informant reports, the data suggests that they actually improved before death. And we don't necessarily think this is plausible, but it's likely to be some artifact of reporting on someone who has since passed away. And so potentially if you're reporting on a loved one who has died in the intervening interval, then you're more likely to have sort of rosier memories and a rosier reporting on their functioning. We thought about different ways to kind of adjust or account for this potential source of bias. And one assumption we could make is that as the time between wave 1 and exit interviews goes towards 0, the difference in the different informant report measures should also go to 0. So if you have a wave 1 interview and an exit interview that were at the same time, this would never happen, but if you suppose in a hypothetical scenario you have this, you would expect the difference to be 0. And so what we can do is sort of model this difference. So the y-axis here is this difference over time, and then estimate adjustments based on the difference between what we observe and 0. So this is what we do when we apply this to the data when we derive these imputations. So these plots show that in the dotted lines, the estimates of cognitive decline for those who survived compared to those who died for each of the age groups, where the estimates of cognitive decline for those who died are based on these imputations. So what you can clearly see here is one, greater uncertainty among those who died. This is because we're essentially fully imputing all of this data, and we're using multiple imputation to account for uncertainty. So we have much higher uncertainty, but we also have greater estimates of cognitive decline. This makes sense. We would expect more decline in those who have died in between waves. So once we have this, we can incorporate these imputations into all of our different models and fully do the full comparison that I sort of set out at the beginning. So this shows the comparison of all of these different modeling approaches, and I'll walk you through some main points. On the left, we have the base model. So this is our comparison model without accounting for mortality. We compare that to these two existing approaches in red and blue. So this is the IPW weighted model. and the joint model. So you can see that both of these have steeper estimates of cognitive decline compared to the base. This difference gets larger as the age groups get higher because we have higher mortality at older ages. And in the 60 to 69 and 70 to 79 age groups, we don't see too much of a difference, but sort of we have the steepest estimates of cognitive decline in the IPW weighted models at the highest age groups. Although I'll note that the number of people in this category is quite a bit smaller than the other categories. And the other thing I'll point out is that the uncertainty intervals for the IPW weighted model are much larger. You can compare this to the estimates from the different imputation options. I have a few different imputation estimates, and these represent differences in the adjustment used for the reporting bias that I mentioned. What you can see is that differences in the adjustment don't make a lot of difference in the overall model estimates. And you can see generally similar levels of decline compared to the existing methods compared to sort of the joint model or the IPW weighted approach in most settings except for 80 plus for IPW. And then at the very end, what we see is the combination of the joint model and the imputation for two of the imputation options. And here we actually see the largest estimates of cognitive decline, combining both the joint modeling framework with our imputations, potentially suggesting if we assume that sort of steeper decline is sort of what we expect, accounting for mortality, that this might represent a really great way to account for multiple sources of bias associated with sort of dropping individuals who've died in between waves. So the takeaways here.
Very few differences. I mean, I mean, they are overlapping a lot. Yeah, especially the two last. And could you say that there is no adjustment for the imputation or for the joint model together? There is no adjustment for them, and it still is overlapping very well with the adjusted. Now, okay, it's how do you need interpretation about that?
Yeah, so the confidence intervals are quite large for all of these estimates. And so we wouldn't really be able to say there's like statistical significance between an estimate that accounts for these sources of mortality and one that doesn't.
But because of the sample size you have.
Yeah, it's in part the sample size, it's in part some of the methodological adjustments we're making. We have to account for some of the uncertainty that we're introducing through those adjustments. It's also just that the signal in terms of cognitive decline, the level of cognitive decline that we observe in the sample is small compared to the amount of noise in the data. And this is true of all estimates of cognitive decline. It's really hard to measure, and you get noise at both time one and time two, and then the signal that you get is quite weak in comparison. And so I think while you can't say there's statistical significance between these different estimates, I think you may have different sort of takeaways in terms of the magnitude of cognitive decline that you'd get from these estimates. So like This is annual change in cognitive functioning. And so if you think about the difference between even just looking at the 70 to 79 age group, where there's a few more people than the oldest age group, with the unadjusted model, I think this would be about like minus 0.03 per year. And then here we're closer to 0.3, even if it's like a 0.05 difference, it's per year. And so if you look at over 5 years or something like that, then you start sort of seeing more divergence in the trajectories.
Right. And for the imputation you use, because there are different ways. In this case, you have some, for example, a maximum likelihood, or you use a non-parametric just for repeated. I mean, which method do you prefer to use in this case? Because in the longitudinal analysis for this condition.
Yeah, I think here I didn't go into the details of the imputation for time. We were using a framework sort of similar to multiple imputation with chained equations, but somewhat adapted to be able to include some of the information from the end of life interviews.
Can I write you just later on about this, the method specifically in mail, if I can?
Yeah, sure. Yeah, sure. Yeah. The paper for this is currently under review too, so that will have all
Okay.
of the details.
Oh, thank you. Yeah.
Yeah. So I'll just wrap up with some takeaways. All the adjustments led to steeper cognitive decline, sort of illustrating that they're accounting for mortality in the way we expect. We were able to incorporate information from the end of the life data despite some of the challenges with reporting, and imputations based on these data were feasible, with final results that were similar across some of the versions that we tested, accounting for bias in different ways. And then we were able to combine the imputations with joint models, which led to the steepest estimates for most of the population. So sort of disregarding that oldest age group. And then overall, sort of wrapping up and summarizing across all the different projects that I sort of walked through over the course of the last hour, when thinking about sort of cross-national research and some of the challenges that come up, looking at the HCAP data, we see that harmonization of cognition is challenging, but definitely possible. And that longitudinal data provides even more challenges that need to be addressed, but methodological approaches exist to estimate potential biases due to concerns, including the two things we looked at here, which are practice effects and interwave mortality. And then I'll just wrap up by saying that I think HCAP data has a lot of promise. And there's a lot of research questions that you can dig into with these data, and they are publicly available, as well as with easy to use data sets provided by the Gateway to Global Aging. So I just on my thank you slide, I just have the links to both the Gateway to Global Aging website as well as the Lossy Dodd Project website. And I'll just make sure to thank the funders and a lot of the collaborators. This is not just my work, but really the result of a sort of broad collaboration encompassing the different study teams, as well as a lot of the investigators at the Gateway to Global Aging. So thanks, and I'm happy to have sort of a discussion, general discussion, and/or any specific questions that may have come up.
Emma, I have a question, and it's related to how much do all these steps and information that you have gathered through the harmonization process help you to understand the contextual influences on cognition that come from different countries, like, for example, India and England, or United States or Mexico? How can you combine those two sources of information, the statistical, psychometric, with the contextual to help understand the process?
Yeah, I think doing this harmonization and thinking carefully about measurement across countries is a really important sort of prerequisite to looking at the different contextual differences. And I think one of the great things about what the Gateway to Global Aging is doing is sort of doing a lot of that measurement consideration for the research community and publishing the already harmonized scores. And so we understand that not everyone's going to be sort of an expert in these like measurement questions, but it allows then the broader research community to take these harmonized scores and sort of run with them and be able to dig into some of the areas where people might be experts in sort of some of these contextual factors. And so some of the harmonized scores are available already, and we're working on sort of updating them with new studies as they're released. And so that allows you to then leverage some of the differences between studies to look at the factors that might have sort of very different exposure distributions across contexts.
Yeah, because you really show the difference between non-educated and educated in India, which is one of the most salient variables to analyze. But there should be many others, like, I don't know, if you mentioned that in India, in-laws are more frequently caregivers or relatives giving information, what difference that makes to compare to, I don't know, to the US, where most of or many people are in daycare places. So it's a nurse or a medical assistant taking care of them. That's totally different, the report they are going to give. And that is based on socioeconomic differences between countries. So
Yeah.
yeah.
Yeah, so I will say I think we've done a pretty good job of sort of releasing data products that account for some of these measurement differences with the objective cognitive scores. And we haven't, to this point, I think, done as good of a job understanding and pre-accounting for, in a way, some of the measurement differences related to informant characteristics. We've shown there are concerns, there are reasons to be concerned, but I think it's sort of a future direction to think about the best ways to sort of recommend that the research community proceed with that information in conducting analyses.
Yes, thank you.
Thanks.
Any questions from other people?
Well, I didn't mind. Thank you very much. Yeah, it's amazing, really, because we have been working with the longitudinal analysis as well, and it's interesting how other people, or in this case, Dr. Nichols, approach the problem as well. We learn a lot. Thank you so much.
No problem.
Yes, Emma, thank you so much. It's a very new area for most of us here, but it's very important to understand that if we don't follow these steps, we will end up comparing apples and pears, So yeah. Thank you so much, Emma. Neida, you have something to tell us?
Yes, I do. Yes, I do. So these are the last August announcements. So for the next Brain and Beyond, which is going to be on Tuesday, not August 26th, but September the 9th, it will be presented by Dr. Michael Lindstrom, and the topic will be coupled nonlinear differential equations and protein biochemistry. Also, we will have a special VIP Idea Lab del Aula a la Comunidad Diseñado Participación Activa, which will be happening in a couple of Fridays, Friday, September 19th, and it will be from 10:30 to 12:45. And it will include a little lunch at 1 p.m. And this will be happening at the UTRGV campus in Bronzeville, BINAB 1.219. And again, this is the very first ever VIP lab in Spanish, I believe. So please, we're very excited about this new opportunity that's going to be happening with the community. And then the last update that we have is that we are still looking for affiliates. So if you are interested in getting access to Alzheimer's disease resources, collaborative opportunities, or consulting services, please get in touch with Ms. Claudia Alanis. Her email is right there below for you guys to be able to join us and share with the resources that we have here.
Mira, there must be a typo for the date for Dr. Michael Lindstrom's date, right?
Yes, yes.
It's Tuesday, August 26th. That's today, is it?
Yes, it's gonna be on September the 9th. So next Spring and Beyond.
Okay. All right.
Okay.
Thank you.
Thank you so much. I appreciate it, everybody. Have a great day.